Sana, go ahead.
All right, I see that you're recording now. Well, thank you everyone for joining us for our very first webinar featuring Sean Clendaniel. Thank you so much for agreeing to give us an overview of your AHEC program. I'm going to start by just talking a little bit about Delta Omega and who we are and why we decided to put this series on. So Delta Omega is the honorary society for public health nationwide. We are the Alpha Nu chapter based in Tucson and Phoenix, and we're associated with the Mel and Enid Zuckerman College of Public Health. So that comprises most of our alumni. And Delta Omega really, what we're trying to do with this webinar series is highlight what is going on with our alumni after they've left the college. So I think it's a great network to highlight what our workforce is doing and get connected with everybody. If you haven't joined our LinkedIn page yet, we do have that. John has the details for that if you'd like to be involved. And if you're interested in sharing what you're working on, we also would love to feature you in one of our webinars. So I'll turn it over to John.
Sana, thank you. Hi, everyone. John McElligott here, member of Delta Omega and working in the Phoenix area. It's our pleasure to have Sean Clendaniel as our guest speaker for this webinar. He's honored to live and work in beautiful Arizona, the Grand Canyon state which celebrated a birthday recently. He loves his job, the people he works with, and the communities and people for whom he does the work. The Arizona Alliance for Community Health Centers, AHEC, and the Area Health Education Center, AHEC, embody his work-related passions, which are healthcare, education, technology, public health, and health transformation. Sean's passion is now focused on launching the Central Arizona AHEC. In addition, Sean holds academic appointments and is actively involved with various governing and advisory boards and committees. Through this, Sean has many strong partnerships with healthcare, academic, educational, public health, social service, workforce, economic, and community-based organizations across the region, state, and nation. It is our pleasure to welcome Mr. Sean Clendaniel. Thanks for being here.
Yeah. Hey, everybody. Thanks for the invitation. What an honor it is to be able to present on some of the work I'm doing and some of the ways I'd like to work with you all and, sharing what we do at the Alliance among our community health center family and in the world of AHEC, and then some particular issues around policy and workforce development. So I'm going to go ahead and do a screen share now. Let me share. So can everybody see that? My screen?
Yes.
Cool. Let me switch it over to slideshow. And it's recording, right? You already did that, John?
Yes.
Awesome. All right. So a little bit about myself, other than was noted. I'm a recent transplant to the Valley. I lived up in northern Arizona in Flagstaff since the mid-90s. I used to always joke, and probably is still very true to this day, I went to Northern Arizona University to support my running habit. I did a small stint in Texas, University of Texas, and I transferred to NEU. I'm a recovering runner, although I still run. Went up there on an athletic scholarship, and that's how I stumbled into health, wellness, and public health. Got a degree, did a stint in AmeriCorps, and that reaffirmed my my love for social justice and public health work. Then I went and got my Master of Public Health from U of A. Right around the time it was actually getting the naming rights of the Mel and Enid Zuckerman, and graduated in the early 2000s. And now I decided to go back to school to be a Wildcat yet again, and I'm part of the Eller Executive MBA program here. It's downtown Phoenix. I'm pointing down the road because it's like a block over, but it's a statewide program. So it's always good to be amongst Wildcat friends and family. So what I'm going to do today is give a high-level overview of community health centers, our Arizona Alliance for Community Health Centers, AHEC, Area Health Education Centers, talk about what we're launching here over the last few months and what we're going to set in motion for the years and decades to come, and then talk about one particular high-need area around workforce, which is physician training and development. So you can read there, that's our Arizona Alliance for Community Health Center mission. Simply put, we're the primary care association for the community health centers across the state. Like any association, you have some core services, of which a lot of it is around advocacy. We have a lot of public health programs, and we do a lot of things around getting the community health centers to work together, but also honoring the fact that you've seen one. Community health centers at their core are very much the same, but they have different scopes, they have different sizes, they have different regions, they have different other things. So we're the group that represents all of them and works with all of them. So, and I'll share there, okay, I went through this slide. We have 25 members. I'll show you a slide here in a second, our associate members, etc. And for those that aren't familiar, federally qualified health centers all around the United States. Here in the state, we have a big footprint. In this last year, we do this thing called UDS. It's an annual report that every health center does. When you aggregate that together, we had just over 800,000 unique patients that were served by community health centers and had well over 2 million, I think it was about 2.4 million patient encounters. So it is a very large primary care health system. And because it's a community health center, underscore the community part, it's always lived by the whole idea of and the tenet of medical home and social determinants of health. So there's a bevy of public health programs nestled within the community health centers as well. You can see there's our strategic goals. Those are the things of which we're focused and fixated on. This is not unlike every other health system really in the United States these days, around informatics and population health and workforce, etc. This slide here shows our family. Every dot represents a unique site. The different colored dots denote different health centers. So you can see it's a big health system spread across the state. The center I came from, where I was at for about 13 years, was North Country Healthcare, and that was all the green dots there. And then I joined the Alliance team this last summer, and that's when I moved down to the Valley. One of the other things that we just were fortunate and honored to get here was the regional AHEC. In a previous life, I used to run the Northern Arizona AHEC amongst other things. Now we're developing the Central Arizona. So thinking globally and acting locally, because we're nestled within a large health system, we're really trying to blow out the community health center workforce development things, which we'll talk about here in a second. But the way that this is designed is that AHECs are all around, like community health centers around the United States, but it's all about local control. Our program office is nestled within the University of Arizona Health Sciences Center and then the Center for Rural Health. Our current director is Dr. Dan Dirksen. Many of you probably, especially in the world of public health, know Dan, remarkable gentleman. And then we have regional centers across the state, and we all work in harmony on a couple of core areas, which I'll talk about here in a second. Before we get to that, AHEC sometimes gets lost, and what the heck is an AHEC is a common thing that's described. It's really a workforce development entity. Really it's about addressing health disparities, but in particularly the health workforce disparities, with the idea that if you grow your own and we focus on primary care and public health, when you think about the best way to affect community health, it's really through that lens. So we do a lot of things in that space. This I always throw in there, but some groups, it takes a little bit more explanation. Us in the world of public health, we know what the social determinants of health are. I think this just gives a good framework of how we think about workforce issues, and that really, if you think about that idea of lifelong learning, if you think about that sense, that's what our AHEC is really focused in on, and that we're really being that conduit and the academic community partner, where we're training current workforce, up and coming workforce, and then really working on health transformation efforts focused on social determinants of health and population health things. So we're really kind of at that nexus and that intersectioning and bringing these things all together. And that's a really unique niche that we are, and really we're focused again on that workforce component. The other thing that we really focus in on, like at a very philosophical level, but it's also part and parcel of most of our strategies. Again, more and more this is talked about, and that's the whole notion of interprofessional education, IPE for short. you know, if you work in the public health space or if you worked in a lot of health systems, we all have to work together and work in harmony with one another, but our academic programs don't always train that. So now there's a lot of emphasis around training individuals to work together. So we do a lot of stuff around getting students and practicing health professionals to working together. We do a lot of like team-based care, you know, whether it's becoming a patient-centered medical home, or we do other things really at the practice level. So again, IPE is a really big thing that AHEC is focused in on. How we do this? Academic community partnerships. That's really the core of what we are. We have a foot in those two worlds. Mentioned where our program office is. And then how we really do this is if you think about the whole idea of a longitudinal experience, we do a lot of stuff with up and coming health professionals. We call these like pathway programs. They're working with kids, even as young as the age of kindergarten. Most of the time it's middle school and up, really giving them that idea to dare to dream, to get them on that pathway to becoming a health professional, wherever it might be. And we can all think back in our own lives, there was these transformative experiences, things were set in motion. How do you keep people connected? And really, how do you address the disparities in health professions education and disparities in health? The best way to do that is to find people from certain disciplines and diversity and train them in those local environments. So really beginning very young. The other thing we do a lot of is all the applied experiences for all the matriculated students. So we all know in our public health world that there's a lot of community-based experiences that are part of the education. It's also true of, you know, physician training, like undergraduate, nurse practitioners, physician assistants, you know, promotoras, et cetera. Everybody has some sort of community-based educational experience. We help arrange, organize, and develop, and then oversee a lot of those experiences. So we're really that conduit to community experiences for learners. A lot of interprofessional education, which I mentioned about. The other big thing we do is because our community health center system employs over 6,000 people, and then because we're an AHEC and we work with a lot of other systems, there's a lot of practicing health professionals, whether they're licensed or credentialed or certified or they don't. They all need some sort of additional training and other educational things. So we're a continuing medical education and continuing education accredited entity. We put on a lot of events. So we do a lot of stuff around the big, broad spectrum of continuing education. And then really community health is it's so huge. That's a lot of what we do, but that's more of a distal measure. We focus on the workforce and other things. And our priorities are diversity, distribution, and practice transformation. All right, so effective this late last summer, we became the regional AHEC here and also the community health center AHEC across the state. And these are really kind of a pie in the sky, 50,000-foot view of what we want to become, but we're also feet firmly planted on the ground, and that this is like a ground floor level enterprise, and it's like hiring staff and developing relationships and aligning our resources. So what I'm going to mention here, these are things that will become, but you know, building for tomorrow we can really affect today. So a lot of these things I mentioned before. One of the things we're really focusing on right now is developing an AHEC Scholars Program. We actually have 2 cohorts of students in it right now. It's a 2-year program, and there's 12 students in each class, and all the students are from different disciplines within the Arizona schools, ASU, NAU, and U of A, public health, MD, PA, pharmacy, and nursing, and they're doing a year-long experience, and then they're continuing on to their 2nd year, and it's really community-based. So our group here is focused on a couple zip codes in the greater Phoenix area and doing a needs assessment and some other stuff. The other thing we're really focused on these days, and I'll talk about this in a little bit, is around physician development and graduate medical education. We're starting to do more and more clinical and community-based participatory research, so we're setting up that structure and doing some other things. And then we're really focused on social determinants of health training, so we're developing a lot of curricular components, and in particular with utilizing community health workers and promotoras. And then, and again, I'll talk about this later, one of the big things we're focused on is advocacy-related stuff and policies at the state level for funding and other things. All right, this is a lot of words. This is just thrown in there, and probably I'll skip beyond it. This just shows you kind of like the sequencing of we got the funding, now we're launching it out, and these are all the very tactical things that we're doing. I'll skip by because it's really into the weeds. So our priorities right now, and I mentioned this before, is really around community-based education with all of our learners. And this is where I always like to engage audiences like this, is that either you are a learner or you're in a position to be an educator. So we really are trying to find meaningful experiences to get students out of the academic towers and into the community. And again, amongst the public health profession, we've already been doing this. But for some that are very academic minded or they're very hospital minded, we want to get those students meaningful experiences out in the community. So we're setting up a lot of things, really focused on primary care and public health. The big thing we're focusing on is, doing a lot of education for practicing health professionals and in the broadest of spectrum, so public health and everything in the primary care space. So this is a lot of things like it could be putting on like a big sort of symposium or conference or lunch and learn workshops, or very specific topical areas like maybe something related to substance abuse disorders or medication-assisted therapy, all kinds of things. We're really developing things and then disseminating out to health systems around the state. So really focused on the workforce issues of right now. Like we need practicing health professionals like yesterday, and then we need those individuals to have educational experiences in their hometowns and home environments. Now I'm going to segue into workforce is so big and broad, but how do we segment it off to where there's probably the highest priority need right now? So I'm going to focus on physician workforce development. So here in the state of Arizona, this last year, a study was commissioned that we currently need 563 practicing health professionals, like right now. So family medicine physicians, pediatricians, OB, and then sometimes that gets lumped in with some like behavioral health as well, like psychiatry. But think about it, in the broad spectrum, we need 563 primary care physicians currently just to meet the demand in place. And these are based upon sound algorithms and methodologies that are used with like distribution ratios, acuity of patients, etc. That's a lot of physicians. We all experience the challenge of getting into a physician, and that's even in downtown Phoenix. If you go out to the rural areas, it's much more dire. Then projecting out till 2030, we need 1,941. So think about that. That's just, we need a lot now, and it's growing exponentially. So if you look at this slide right here, it shows you per county. Again, Maricopa County has a disproportionately high need because of a higher population, but every county needs a lot of physicians. This right here is a thing that we use. If you're not familiar with it, it's called the Health Profession Shortage Area. HPSA score for short. It's a methodology used to assess need. The higher the number, the higher the need. It's used for a lot of things around federal funding, whether it's things like scholarships or loan repayment, or designation of certain sites for getting federal funding and state funding and other things to train individuals. So it's a pretty important number. Here in the state, pretty much every community and every population, and even very specific to census tracts, the scale, like the need is off the charts. Right now, it's about 42% of our primary care needs are being met, which is really, really bad compared to the rest of the states. In fact, we rate 44th. So there's a few states behind us, but there's a lot of states ahead of us, and not in a good way. Then you overlay that with our current growth patterns and not just the growth patterns, but the aging population. We're really in a dire circumstance right now if we don't start really fixating on the physician workforce issues. So that kind of shows the need, and now I want to segue into really what's happening around the state and some policy-related stuff and some opportunities for training. So not to get too into the weeds, but if you're not familiar, graduate medical education is also known as residency education. So undergraduates do 4 years of medical school, graduates where they do, graduate physicians do their specialty, so family medicine being a specialty, cardiology, etc. But at the graduate medical education level, at the federal level, the funding's been capped since 1997. It was part of the Balanced Budget Act of the Clinton administration. And because of that, a lot of academic medical centers have not grown a lot in the graduate medical education space. That certainly holds true here in the state of Arizona. However, in the last about 10 years, the undergraduate component has grown exponentially. I mean, in that time, you've had AHEC University that's grown into the state significantly. You have Midwestern that's doubled their class. You have an entirely new University of Arizona system here at Phoenix. You have the Mayo program. You have all these individuals that are now going to be trained in the state, but without graduate medical education growing, it's going to be likened to brain drain. People will be forced to leave to get their additional training. And this is a real huge issue right now. And the best predictor of where a physician will actually practice is where they train. Most physicians practice within 50 miles of where they did their residency. So, is there sorry, it's the chat. All right. So lots of stuff has been done over the last couple of years, one of which is, sorry, my slides aren't forwarding. Oh, there it goes. Okay. You can see here in the state of Arizona, a lot of graduate medical education is funded through CMS dollars, Medicare dollars, and also flows through Medicaid dollars here. However, in the state of Arizona, we've been plateaued out for funding for the last about 10 years. In fact, the state actually does not contribute $1 towards graduate medical education. The last year, with a lot of the tax that programs are putting on themselves, they're funding it, but the state has not funded this. And so you can see this growth has been fairly stagnant because of that. This last legislative session, because of a lot of work done, especially by Senator Heather Carter, a lot of good things have come. Hopefully that's a harbinger of things to come in the next sessions, but there's some unprecedented dollars. So if you're not into the world of policy, I just kind of went through and picked out some of the high-level ones that are really focused on our rural and public health needs. In particular, that first line item there is that now the state will appropriate $3 million this coming year, and then I'll get to another slide where it scales up over the next year so that we can start to draw down those federal funds as well. And this will be designed to really grow a primary care physician workforce issues. One of the other things that rolled out this last year, and they just accepted their inaugural class of recipients, is the University of Arizona got $8 million for scholarships for students, medical students. And this is a huge issue because the amount of debt that medical students are coming out with is just off the charts, averaging about $200,000, sometimes significantly more. That's oftentimes one of the biggest impediments to doing primary care or doing rural medicine because the debt level doesn't pencil out. So by able to keeping those costs down through scholarships, it's going to hopefully make a big change. And then the other thing that's done as well is a state loan repayment program. It's been funded the last couple of years, but this gives it a lot more solvency. And this is another way that we can incentivize people to practice in rural and underserved communities because it helps pay back their loans. And it's somewhat shameless, but the center I used to be involved with got a bunch of funding for its residency program up at North Country Healthcare. So this shows you that thing I alluded to, the $3 million, then it goes to $6 million, and then it goes to $9 million. If you do this match with federal to state dollars, you can see that within 3 years from now, by 2022, $30 million additional dollars are going to come into the state, really focused on hopefully the physician workforce issues. And the goal is the highest need programs in the highest needed areas. So again, primary care, public health workforce. Now I'm talking a mile a minute, so hopefully this all makes sense. Before I go to the next slide, so the old cliche thing, every system's perfectly designed to get the results it has. I think when you put an emphasis on acute care, academic medical centers, there's not as much emphasis on a primary care workforce issue. So as us as a big health system focused on population health and really focused on, say, family medicine, we need to want to design residency programs that are nestled within community health centers. John, did you have a question? Oh, sorry, okay. Looked like somebody had their hand up. So what we're working on now with that idea of like the need, the funding, the policies are all lining up is redesigning how graduate medical education can be done, and not in a revolutionary way. It's highly accredited. All we're asking and all we're designing is that let's do this within a different environment. Let's do this within a community health center. Let's do this within a community-based organization. Let's do this within an organization that orients themselves and organizes themselves around social determinants of health and medical homes. And in my humble opinion, that's the space that community health centers are in, and that's how they're designed. And really, it's the very ethos of who they are. We just need to have the funding come to us to be able to organize graduate medical education things. So what I was involved with at North Country, we're hoping to scale out here in the Valley and across the state. And at a very conceptual level, you can see these two schemas. One is traditional model where all these funds go to an academic medical center and they organize it. They have the institutional sponsorship. They have the hiring and firing, if you will, of staff, the program director and residents and others. And it still meets the same rigmarole of accreditation. What we're saying now is transition that sort of concept into a community-based organization, a community health center, where the money comes into it, and it's the one that's entrusted with, organizing and being legally responsible for a residency. So really, it's just this whole notion of creating a teaching health center. And so that, try to keep to about 25 minutes, but that's a really high level of the Alliance, a really high level of us launching a center focused on workforce, and then one particular issue around graduate medical education. And this is the mantra we live by, and it takes working with you all on this call and everybody else is working together, aligning resources, and really letting community needs be the dictator of how we organize ourselves.
Sean, thank you very much. If we had one of those like clapping tracks that you have on TV, then we'd play that right now. Thank you very much. I'm going to open this up to questions from the floor. So folks, if you have any question, please unmute your line right now and go ahead and ask.
Okay. Sean, that was great. Thank you so much.
Yeah, go ahead.
I don't have any particular questions at the moment, but I learned a ton, especially looking at those dollar amounts and the information about the state. Really interesting stuff. We'll post this to our LinkedIn page, and I'm sure you'll get more questions directed your way once more people have seen the presentation.
Yeah, this is like a digression. I'm a public health professional and really fixated on the policy side. And when I started thinking about this and getting more and more involved with this, I kept coming back to this really simple question. Why is it that CMS, a system designed to pay for largely Medicare, is the biggest payer of physician training in the United States? I mean, it was just really interesting on a policy level. And then you think about follow the dollars, and they go to graduate medical education enterprises that are focused on subspecialty care. And it's just a real big flaw in the system. And so we're trying to be that kind of disruptor and like getting new funding sources and doing things in different ways. But at the end of the day, it's really not unlike it would be for any other entity that's organizing itself around it, something that's highly accredited. It's the same dollars, just used in a different way, and it's organized by a different organization.
Yeah, I'm pretty deep into the public health system, and that was brand new information to me, so thank you again.
Yeah.
Any other questions or comments for Sean? Okay, well, so we can stick to time. We'll end it there. Sean, thank you very much for being our first host on the Delta Omega webinar. We hope that you'll come back. Anyone listening to this, please let us know if you'd like to speak on a future webinar. Reach out to Delta Omega Alpha Nu chapter at University of Arizona. Sean, thank you very much.
Yeah, thanks everybody.